So welcome to part 2 of our discussion with Brady Green, where we'll pick up from where we left off in part 1.
I've had this problem recently, and it's been a big error on my part of when you have a good relationship with the athlete at a professional level, and if you guys, it would be the players that have been there for 7, 8, 10 years, and you start to make assumptions about, that's not going to change, so we won't touch that. Even though if you came to it, as I say, with a child's mind, and you came to it naive, you say you were the new clinician, you'd be like, that's actually something really important.
Yeah.
It's a mistake I know I've made a lot of times, and I've had to kick myself in the ass and say no, this athlete can't get away with having terrible ankle range or terrible hip range just because they've always had it and I've let it go. How do you sort of reconcile that with some of these players who, I'm sure the injuries are probably significant, particularly joint pathology and stuff like that. But in your mind, you're thinking, okay, well, are we avoiding this at their detriment because we're actually almost using that label of the pathology or going, that's just them.
That's just what it is. And really good point. And I think that's a luxury of perhaps working in a team environment where, there's 2 other physios within our team. We have 3 S&C coaches. We have 2 doctors. And we devote time to discussing each case. And everybody has the ability to give their perspective, which are varied in terms of people's expertise and knowledge, and also in terms of people's personalities, which I think is important in a team dynamic. So that's perhaps a nice part about working in a team, in that you can lean on others, you can utilize their expertise and perspectives. I've certainly found that helpful in that regard. Yeah.
Can I ask a provocative question?
Of course.
And I'm sure it's an evolving understanding, because if you had this answer, you'd probably be a billionaire and wouldn't be wasting your time working clinically. But with all of, you just mentioned, you've got really intelligent people who are communicating and working day in, day out. Why do we still, do you think, in your mind, see so many, say, soft tissue injuries in a sport like AFL, where you would think the resources across the board, and every club has these injuries, so it's not unique to one club, even though there are clubs at times who go through spates of injuries. Why do you think we still see so many of these injuries? We've had these discussions, but I'd like to know from someone who actually lives in clubland and works there.
Yeah. No, it's a conundrum that we think about often, but there's no escaping an exposure risk. In the data would suggest that just the fact that people are exposed to injury mechanisms, at some point, it's possible that they will be injured from that injury mechanism.
Do you think we're getting closer to understanding these things, or do you think potentially, because the thought that I always come to, and Jack and I have spoken about this, outside of this setting, but that maybe fundamentally we're looking at the problem in the wrong way. And for that reason, we're not necessarily getting closer to eliminating or heavily reducing these injuries. And that's with no understanding of what the answer is, but just saying, if we keep seeing the same problem, we keep approaching it with the same process, maybe that process is the wrong one to, we're using the wrong tool to try and fix the problem.
Exactly. And
I'm putting you on the spot because I didn't tell you we'd be asking you something like this. It's very, very broad and very,
But you meant to have all the answers.
I've done my PhD in calf injuries, so that means we can never have a calf injury ever again.
That's what it means.
I'm sure. But if tongue in cheek, if we talk about the calf, for example, something we like to do as physios is measure strength. And a key clinical message over the last few years is that, it can be helpful to have strong calves, and certain strength metrics are presented on, for example, being able to produce torques over 2 times your body weight and things like that, which is really nice. And for clinicians, and with our quantitative hat on, we can perhaps have safety in that. In that the athlete will be able to and be resilient to the high peak forces that they encounter when they run. Great, tick. But you can have the strongest calves in the world, but then complete a running exposure that you're not prepared for, and you still strain your calf.
Yeah.
And there's no escaping that.
Yeah.
And the AFL is perhaps a unique sport in that, say in the first quarter a player gets injured, and the rotations go out the window, and certain players end up completing a workload that they're not prepared for. In the heat of battle, that's unavoidable, and that's an unavoidable risk. And 8 times out of 10, everyone's fine. But then you can pick up injuries from that.
That makes me think about, I know that there was I hate this term because I think it's not the right term, but the utilization of these discussions around like introducing chaos into the rehabilitation process, and a number of research papers like to put that as their title, or use that word. But are you throwing curveballs at them in training to do stuff like that, where it's like, and it sounds, as I put my coaching hat on with this, right? One of the things that you often do to see how your athletes respond is you do things that they don't expect, right? On purpose, because you want to push their buttons and you want to see what happens. In the hyper-professionalized world of football now, are coaches pulling stuff like that? And you guys are almost tearing your hair out, or maybe if you're really intelligent, you're planning it ahead of time, you tell the players, oh, we're out for 2 hours of on-field stuff. Then all of a sudden it's a 4-hour session and they don't know about it. Right? It used to be the sadistic thing of like, you're just going to keep running until you're all bleeding from the eyeballs.
Yeah, we certainly, and this is more driven from our head of high performance, we have certain sessions where we are a bit coy
about what's going on,
the information that we give to the athletes, so that they don't precisely know what the session will entail, because it's going to be a big session. And
I think a better way to put it is like, John and I often talk about constraints. So, in a training environment, you can create as many constraints as you like to control.
Yeah, you can keep it as closed as it can be for that context.
Because I also think, too, like going back to the example you gave of an unexpected injury and that affecting rotations, it's not just about the actual physical workload, but actually the psychological impact. Because
I'm going to have to play more minutes than I normally do.
Or a different position.
Something
like that,
And there's probably I think there's a lot more to really understand about how your psycho-emotional state impacts your physiological response to mechanical or physical load. But that's probably always a bit of a challenge. Like, how do you actually create that situation where you go, you know what, I'm going to mess with you right now. Yeah. But do you do that, John?
All the time. Yeah, all the time. Like, you'll throw things in, and these days it's probably not so much with the programming, but it's kind of like maybe how you respond to something, whether you give feedback to something.
So it's not so much the actual physical training that you go, you know what, I'm actually going to do this. It's more.
Well, sometimes you do. You go, oh, we're going to do this rep, or I'm going to throw you in with this person. Yep. So it is much more of a physical challenge. But like, one of the ones that I started doing a lot more, which sounds, it's very minor, but like, I used to travel a lot to every competition, and I've started to become a lot more judicious with that. Of like, I'm not going to be there, so get used to it. Know how to like prepare yourselves, and like, I think interestingly, like, I don't know whether they're even doing stuff like that at football level. It's like, oh, there's no coaches on the actual deck today. Like, this is the drill, this is the session. We'll be watching, but we're not really doing anything. Are they giving them the opportunities to kind of, psychologically prepare for that? Because obviously on the field, yes, messages go out with the runner. And I know that a few years ago, they kind of cut back on how many messages could go out and what could be said and all that kind of thing of like, how much of the players actually making decisions out on the field, which is very often, right? How good are they at actually being able to do that if you're not exposing them to those opportunities? And I think that's one of the things that, even as a clinician, as we've discussed a number of times in this, like, we like the protocols because it removes variables, it creates more certainty. I don't think ourselves we're good at being uncomfortable by like throwing in our own spanners to try and see how, as a clinician, how do you actually deal with that? How do you deal with not being able to have hands-on intervention going all the time? And it sounds silly because in your setting, you're all being paid, you're all like very high-level clinicians who are being asked to look after these people for you to walk away and say, well, today we're not doing anything, right? Spend for yourselves. Or here's your rehab plan. I'm going to watch, but I'm not going to say anything. I'm not going to do anything.
Yeah.
You like, go for it.
Yeah. Like, people are certainly identifying different ways to challenge the guys. But perhaps not to the extent that that you're able to do.
Like, is that a discussion that, you know, I'm sure your club has a psychologist that works with you. Is that all right to assume?
Yep.
Are you guys talking about it at that level of saying, like, actually, this is an important thing to take away some of the, take away the blanket from this person and let them kind of experience this a little bit more to build some of those sort of
and resilience. And I think what I think about in that regard is, there are certain pathologies or niggles that you're dealing with that mightn't be severe, and you might be comfortable within the team about pushing that along a bit. But sometimes you can have young athletes who are inexperienced dealing with injuries. They're inexperienced having symptoms while they're trying to perform. And at times you either need to sort of help them along through it, but at other times you need to just let them go a bit, and not not overcheck them and not overcheck in with them and ask them every 5 minutes.
How's it
how's your Achilles tendinopathy? Because in my experiences that creates hypervigilance and it creates a over reliance on the medical staff. So in some scenarios that might be seen as not showing care, but it's the opposite. You're actually trying to
build some of these tools for them,
build resilience in the athlete. Yes, they can deal with little niggles along the way. They don't need us to tell them whether it's okay to keep going or not, and they can make those sorts of decisions themselves. And I think that particularly in the first to third years or first to fourth years, those real formative years when an athlete is developing, that is a key period where it could go the other way, and you could create hypervigilance, and you could create athletes that lack resilience and the ability to show grit and a growth mindset and things.
That's become a super interesting area for me as a coach, and I think it's very heavily influenced the way I view clinical problems and communication in clinical problems. Is that something that you've used the terms that come from that psychological vernacular? Are these things that you guys are talking about? Are you being upskilled on it? Are you working with, say, the psychology staff to actually make sure that the way it's communicated about is, meeting some of these understandings?
Yeah, so we're really lucky. We get learning and development training at the club, and the club invests a lot in our development. So there is that going on in the background, and then where appropriate, the welfare staff will always be involved to whatever extent is needed. But I guess as a team philosophy, something we talk about a lot. If I can use an example, is say manual therapies, and a young athlete's approach to preparatory exercise and prehab or working on their impairments. From day dot, the young guy who has a tight hip, are we going down the path where we'll spend 20 minutes with them before every training session doing some soft tissue and trigger point to release their hip? Or are we perhaps doing a little bit of that, but then as soon as possible, empowering that athlete to be able to work through a series of mobility, recruitment, strength exercises that they can self-manage. They can see the benefit of that because they go into a training session with less symptoms. And in that sense, that's more of our philosophy.
And is that being driven, that philosophy, is that being driven by the performance team and the medical team, or is that being driven as I said, like with specific input from, say, welfare and psychology?
It's more our philosophy.
Yeah. And do you know where that's developed from, or is that something that precedes you?
I think as a profession, we're becoming better at identifying which situations we utilize certain tools, and gone are the days that you treat everything with your hands. And certainly, if we were just treating things with our hands, we'd have less scope to focus on the big rocks. So at the end of the day, that's also recognizing our small part in an athlete's success, in that, we should be doing everything we can to ensure that they can complete the biggest rocks, e.g. training at a very high intensity, completing their gym at a very high intensity as best they can, and we support them in doing that, and us not being confused that their success is because, we did a really good hands-on session. We did some really good manipulative work through their spine, whatever it is.
You fix them, so to speak.
I fixed,
I imagine you get the whole spectrum of personalities, though. Some people who are going to be much more willing to adopt that, whereas they're much more, maybe not even dependent, but want you to be a lot more involved, in terms of, I need my bit of manual therapy or so on. That's probably dependent on those first sort of 3 to 5 years, hey?
Yeah, and, this isn't criticising the role of manual therapy either. It's more just a general discussion about what we're doing on a day-to-day basis and our general philosophies, because certainly there is a big role for manual modalities in athlete preparation.
The way I often look at it is just like any exercise where what are the actual neurophysiological adaptations you're going to induce from manual therapy, and is there enough actual stimulus or magnitude to induce the changes necessary for that person? Because there's obviously a limitation to how much mechanical force we can apply. Though it's probably not to disregard the actual psycho-emotional impact of touch that you can have too. I was actually interested to ask you, how much conversations do you have with the athletes around some of the non-physical factors, like in regards to, say, recovery, sleep? Those are the, what I consider to be pretty significant rocks with regards to how they respond to their training and how they actually recover.
Yeah, so, these guys are pros in the sense that when they get a niggle, an injury pop up, they often ask directly and often on a daily basis, what can I do? And that's a good opportunity to say, I need you optimizing your recovery, upregulating your sleep and ensuring that you have good sleep hygiene, catching up with the dietitian if it's relevant, and covering off on all of those bases. So we utilize those opportunities almost daily.
Yeah, okay.
Yep.
How much do you see those factors relate to someone's development of an injury? Like, do you often see patterns where there's changes in someone's behavior, or like there's even things going on in their personal life that have an impact on their prevalence of developing an injury?
Yeah, it's possible. Various different times. There's no escaping stress. There's no escaping the impact stress can have on your physical output and injury risk. I guess we try to put monitoring systems in place that detect flags, and that could be subjective information, and we get the athletes to complete wellness and rate how they're feeling and a few different things like sleep quality, and then we have our objective monitoring as well, where we're testing physical capacities, and fluctuations or changes in physical capacities can give us information about the state that they're in on that particular training day, because we do have the luxury of serial testing in a homogenous group of athletes over a long period of time, and we get an appreciation for what is normal for that particular athlete on that particular day.
Do you do any data collection on some of those non-physical factors like sleep monitoring, or like even looking at, say, central nervous system state with some of the what's the technologies?
Omega wave.
Omega wave.
Not at the moment.
No, okay. Because you started using some of that stuff, don't you?
Yeah, I found that super helpful. Obviously, you get sympathetic, parasympathetic tone through some of the things like HRV, but I actually found the measurement of brainwave activity probably more relevant, particularly for the high speed, high power event.
Yeah.
The heart rate variability seemed to be pretty consistent and not drop off a cliff as much. Like I had one athlete when I first started coaching him. He was constantly complaining of niggles and things like that, and we sort of said, okay, well, we need to get a much better picture of this because we trialed a few different sort of microcycle lengths. We were trying to fit him into trying to get 3 or 4 bouts of reasonably high stress training sessions within a 7-day period. What we found is basically at the start he could only tolerate like one really high training stress day and high intensity once every 10 days, which was one interesting and two frustrating because you like clearly you
need a bit more training density.
Yeah, you need to be able to expose yourself to training to stresses at a much closer sort of density than that. The good thing was with the application of training and putting in some better, as you said, like recovery factors, especially for him was around sleep and food and things like that shifted into about 7 days.
Is that also reflective, do you think, of his training age and history?
Oh, of course.
Yeah.
Of course.
Do you expect that to change, do you think, over time?
Yeah, well, I hope it changes. Because, well, the reality is this, is if you want to be, it comes down, we often talk about the idea of like a needs analysis, right? And in the sport of track and field, you need to be able to run fast at least probably once a week, because that's usually a competition structure cycle. But if you get to a really high level, you need to be able to do multiple days. You need to be able to do that across an extended period. So say if this athlete is fortunate enough to be in a position to make an Olympic team or something like that and run an individual event and then a relay or something like that. Obviously, I coach sprints, so that's a possibility. They might run heat day 1, semi and final day 2, then have 2 or 3 days off, then come back and run heat of the 4x1, final of the 4x1, hopefully. So you've got this situation where they've got 3 rounds in 2 days, then they've got a day or so off, and then they've got another 2 rounds. There's no way that athlete right now would tolerate that density of high intensity loading, right? So your needs analysis goes to, okay, well, where do they eventually need to end up and how do I slowly bridge that gap? And I think it will get closer. I hate to think of the idea that, maybe because of his training history that he's set into this pattern for an extended period. I think it's going to take some interesting challenges to slowly close down that space. But yeah, I think it's going to have to happen if he wants to reach the requirements of where he would like to go with his sporting career.
When you say challenges, do you mean from a physical perspective or psychological, or both really? Well,
the good thing is this athlete's really committed and really understands and is really good to work with. So it's not a problem of like him buying into the concept of, okay, I've got to get more high intensity training days in. I've really got to maximize my sleep. I've really got to maximize my recovery, my food intake, making sure that, he works full time or part time, but nearly full, like he takes his 4 days a week. So it's like, I'm going to we'll structure the days so that his intensity sessions are on the days that he can, have more rest and sleep in and all that kind of thing. That's not really an issue because he's fully committed to that. So psychologically, I don't think he's unprepared for what that requires. But physically, I think the early part of that, his reporting will be, I'm pretty sore. I'm not pulling up that great from this, and from a performance measure, what you see is initially you see a decrement in their ability to maintain that really high output. And then they start getting niggles and soreness, and then eventually it'll lead to some sort of injury if you keep pushing that. It sort of sits on that spectrum. So, yeah, I don't think he's unprepared for what that entails, but I think it's going to take a lot of manipulation on our part to get that balance right. I think it will, be interesting to ask you, Brady, with those younger guys coming in, how strongly are you vetting their backgrounds? Particularly, I always think it's really interesting because to me, I think one of the biggest downsides of coming through, say, the NAB League, nowadays TAC Cup, so I always call it TAC Cup, but is that you're playing against kids. So the physical demands are actually way lower than if you're playing against adults. And I've always thought that the guys who come out of South Australia and some of the country footy kids who play senior football at 15, 16 are actually more prepared physically for the rigors of the physical contact, particularly much earlier than the players that come out of TAC Cup, right, or the NAB League now. And not from maybe a skill perspective, because I think they come out with maybe higher skill sets and they probably have some of these other factors. But I kind of, and this is obviously completely anecdotal, but they just seem to be ready earlier. With you, when you guys get these young guys in, how much are you vetting? Okay, what have you actually done? What kind of training was it? What's your history with playing, and what have you played at a very high physical demand level? Maybe against men who are much older and more physically capable.
To a high level, and certainly we'll have information about somebody's recent playing history and training history before we have them. And their injury history as well. We'll have that information. And as soon as we have them in the program, we're refining what we understand about them. We have specific screening that we go through to test their capacities and their movement abilities in certain areas.
Do you test their training tolerance in terms of like overall loading?
And that's difficult to do, obviously, before you have them.
But once they come in, say like first preseason, I'm sure it would vary the cohort that you get for you new guys that come into the club. Some of them are obviously from other clubs. Some of them are draftees. Some of them maybe rookies that have played at senior level.
So there is a bit of suck it and see with some of the guys.
Experimentation to see what happens
once they start to train, and you're certainly monitoring their exposure, their response to exposure really closely. But you can't always know in those early days how they will respond. And I made reference to some of the objective monitoring that we do. And it probably takes a couple of months for us to get a true profile of what we observe in terms of some of their strength and power capacities.
That's the hard thing, isn't it? Because you want. I always found like you want to react to it, but it's like
you don't know.
You've got to wait. You've got to wait. Collecting the data.
To see the pattern.
See the pattern. So we have young guys that it's normal for them. Say if we're talking about their hamstring strength after they've played, they might normalise in terms of their hamstring strength until 5 days after they've played. And that's their normal recovery profile. Versus other athletes.
Do you see that correlate to other areas? Like, do you see that, okay, if one isolated tissue measure is taking 5 days, is that a correlate for you for anything else?
So that's me with my physio hat on. And that would be a correlate of their ability to execute and withstand proper high velocity running for sure. And
you're finding people that potentially this part of early on when they don't have, say, that training history, that those numbers are bigger, and then you're going, oh, maybe this player's not even really ready to play 7 days apart. Or on shorter turnarounds, if you play Sunday and you get a Friday night game, like, are you considering this stuff?
It's a consideration, and particularly in the area of adductor-related groin pain and groin overload, and the young guys that can drop off a cliff in terms of some of their objective testing, but also then having clinical signs as well. As the season goes on, it does become a consideration in that, you
need to risk someone.
You don't want to compromise their health long term, and you want to do best by them and not set them up to develop a more sinister pathology in that area.
You talking before, John, when you were talking about that athlete, there's a question I wanted to ask you. Do you at the club, or do you personally think about profiling different types of athletes based on either the position they play or how they play? And also, and this is probably something that you may be able to quantify, but it's more of a clinical observation of seeing the kind of athlete they are, whether they're more that fast twitch type profile versus more of that slow twitch profile.
Diesel engine.
So we're really lucky. Our sports science and strength and conditioning guys do some really excellent work with monitoring of running profiles. and establishing what's normal for someone within a training session and within a game. So you get a really specific output, and you can profile their running based on that. Guys that, are your explosive, high speed, really high acceleration and deceleration numbers, versus your guys that might have a really high volume of output, but more cover, high meters per minute, not necessarily running quick, but covering ground.
Do they train differently because of that?
There are some differences in how you might go about some of their gym-based prescriptions.
And not so much like what they do on the actual ground?
Some of the running conditioning, there can be changes, but once you're in the in-season period, like the main drills are the main drills, and everyone needs to be in the main drills, and they're sort of in their positions anyway. So once the season starts with their running, there's perhaps less scope for that. But that's not to say there aren't guys that are doing, additional plyos, additional drills, additional running conditioning on the track. There certainly is that occurring. But I'm just sort of making the point that there can be less scope once the season starts.
This will sound like almost a ridiculous question, but do you think that there are certain profiles that are maybe being understimulated by even this high level of input that you would see at an AFL club?
I'd say that it's possible. Yep. Yep.
Do you, John? Like, what are your thoughts on it?
Well, obviously, I'm not in that environment, so I don't know. But it's always interesting to me that there are certain athletes who, depending on, and it's not necessarily understimulated in terms of volume, because I think everyone straight away runs to volume of like, oh no, we did, 30 hours of training, so how can that be? And the example would be, because I know that most people will have thought of this, is, the number of high speed, meters that someone's doing across, a period or a week or whatever it is. And for those who follow like NRL, there was an article by, in the paper about one of the top players from Manly, Tom Trbojevic, who kept doing hamstrings. And the medical staff decided, and looking at the data, actually, he's not doing enough high-speed running minutes outside of the game. Therefore, his hamstrings don't tolerate it when he does go into a game. That's why he keeps doing his hamstrings. So they make sure that he stays over a threshold. And I think about that when you have different profiles, and sometimes it's going to be for people who require more aerobic type activity, people who need more strength work, people, as you said, who need more, elastic plyometric type stuff, whether that's actually occurring. Because the challenge, I think, for you guys in your setting is there's so many people, there's so many athletes. And yes, you've got lots of staff, but you're dealing with large numbers, and sometimes it's hard to sort of pigeonhole them into their groups and be able to do that in a cohesive manner when you're trying to play as one team.
Yeah, the practical challenges.
Yeah, I remember, it made me think of that. I can't think of the author's name right now. Pretty sure it was a study from Australia looking at correlates to fascicle length. And one of the biggest correlates was the chronic high velocity running. So it's like just thinking about what are the key things that you need to do to actually potentially maintain, say, a certain muscle architecture that might be correlated to injury risk as well. Does it influence, I was going to ask you too, going back to thinking about different profiles, does it influence you, or from a rehab perspective, do you tend to think about the type of profile they are, and if they have an injury, what kind of stimulus they may need?
That's a key element to rehab design, certainly, from baseline. And we can tie that in with what we know they need to get to in terms of how quick they run, how many meters they cover at certain speeds, how much they accelerate and decelerate. So we do have that luxury that, we can, from day dot, tailor it based on what you see.
So that'll influence a lot of their running programming as you start to get them back towards performance?
It'll influence your exercise selection and what you need to see from them before you sort of push them along and progress them to the next stage. And I guess that's where we've touched on this a couple of times, but for your run-of-the-mill 3-week hammy, because every hammy is a 3-weeker.
Absolutely.
You have a framework,
Yep.
But then based on their profile and what you need to see from them when they return, you're diverging from that at key points along the way.
This is probably a good way to put it. Thinking about that argument of should we be following protocols or should we be following frameworks, and particularly in the environment that you work in, if your amount of time resources you have is quite limited, following a protocol can be quite a useful thing. And then how much time you actually have with the person will give you an opportunity to determine how much you can deviate away from that protocol based on the individual's needs and requirements. Yeah.
There's a question that sort of popped into my head as you were talking about that last bit, but it's a little bit off track. But something that interests me, and I know that it came up in some of the research that you did, particularly with the MRI study that you took the data from the AFL, is the involvement of things like tendon tissue in soft tissue injuries, whether it be calf, hamstring, quadricep. It seems like it's more prevalent to have tendon involvement these days than in the past. And I think that in many ways that's an observation based on the fact that we're doing a hell of a lot more imaging. Where do you land on that? Do you think that those injuries were always there and now we're seeing more of them because we're imaging them and the imaging quality is much higher than it was previously? The actual quality of MRIs and the people reading them is really, really high in sports medicine now. Or do you think that we actually are seeing a greater prevalence of them and that's due to the factors relating to the, say, intensities of the games and the activities that we're doing, or potentially even the profile of these athletes, their training histories and what their bodies are capable of doing in this sort of more recent context? And that last bit, I think we've noticed a little bit even in here, more of these type of injuries coming out of COVID, right? And to me, and this is unsubstantiated, but it's my sort of working hypothesis that the lack of activity through some of those periods, particularly exposure to gameplay for some of these field sport athletes, has left their tissue unable to deal with some of the mechanical tension that's created when they are exposed to those activities. Do you have any sort of working ideas on where it lands with that?
Yeah, first and foremost, from a scientific point of view, really difficult to substantiate.
I understand, but we're asking for your opinion.
So, with another 10...
We've just had the election, so...
With another 10 years of data from the soft tissue registry, I think there will be information in that regard. Some clinicians who, are far more experienced and knowledgeable than myself would say that these tendinous and aponeurotic injuries were perhaps around previously before we could really understand them or diagnose them with MRI as well as we can now. And they were perhaps the ones, the 3-week hammy that you try and play on week 3 and they re-injure, and then you try and play on week 3 again and then they re-injure. And you sort of have 3 or 4 recurrences before you get anywhere. Whether or not that's true, it's difficult to say. And then one thing I think about, you're asking with respect to the quality of imaging and imaging classification, and certainly we know a lot more in terms of being able to describe injury locations. But even so, it can be challenging. Yeah.
Why is everyone all of a sudden keen to put out their own classification system for MRI these days? Is that like the new fad or something?
Yeah.
Every time I read a paper about imaging of soft tissue injuries, we've designed a new classification system based on our own interpretation of it. I read another one yesterday. I was like, what is going on here?
Yeah.
There's also this issue at the moment too, where clearly location has relevance, but you're also seeing this current trend where radiologists are essentially trying to give the prognosis of an injury, going, well, it's got this amount of involvement of the tendon, it's more proximal, therefore it's going to be this long.
Yeah, and that is, as professionals, we all have our sort of area of expertise. And I think one thing that can be challenging is, what is defining what does tendon or aponeurotic involvement mean? And, there's really excellent work from Michael Carr and his group of researchers in Europe, where they show that a lot of the fibrils between your myofibers and your tendinous tissue interdigitate at muscular tendinous junctions. So strictly speaking, even your classic MTJ strains and things, as we know, technically they're still tendo-aponeurotic injuries. And, that may seem like a basic point, but I'm just illustrating that, there's perhaps connective tissue involvement to some extent,
so it's hard to separate
in even the most rudimentary muscle strain injury. And even some of the most recent work from the Spanish group, Raymond Bailius and Carlos Pedret, have been looking at an even greater level of detail at what it actually means to have tendinous involvement. But where I'm getting to, I guess, is that as a clinician, I try to follow a really simple process, working from what is the muscle, what is the location within the muscle, yes or no, does it look to involve connective tissue? If yes, what is the extent of involvement? And can you see any other changes in that tissue that may be clinically relevant, such as detensioning or waviness? And I'm not suggesting that all of these changes automatically equate to a finite prognosis at baseline, but I think as a clinician working in the AFL, it's important to understand the precise pathology that you're dealing with. And
so for you, sorry, I'm interrupting you, but I think it's an interesting area, is for you when there is connective tissue involvement to an extent greater than maybe that basic MTJ injury, what does it mean for you, and what will you see with that? And then for you at a conceptual level, what's happening in the tissue that means you've got to implement different maybe interventions or time periods? Like what do you actually...
Yeah, good question. And everyone has different opinions about this.
What it actually means and what's it doing to the tissue.
Some on the basis of pathoanatomical classification would set a prognosis at baseline and stick to that, which, setting a prognosis at baseline can impede the process either way. It can slow you up if things are progressing really well, or if you're tied to a prognosis and things aren't tracking as you expect them to, you could potentially hang yourself out to dry and play them too early and risk a poor outcome. So where was I getting to with that?
I was talking about how it influences your own sort of clinical decision-making process once you have that information about connective tissue involvement. Like, it actually ties into the question I was going to ask, is do you actually think it's necessary to get imaging to have a full understanding of the injury, or do you think that the clinical presentation itself provides you the information you need in terms of what needs to be done from a rehabilitation process?
I would say it depends.
Good answer.
Well, that's something I always find difficult to deal with, where one of the challenges you have is there's an expectation of we need a timeline early on, day 0, day 1, 2. It's like we want to know, is it a 3-week, 4-week, 6-week injury? It's always amazing to see the variability in response from that acute to subacute phase.
Yeah.
And this also highlights, again, the process of an injury isn't just about the severity or location. It's also about the response of the individual to that healing process.
Precisely. And in some of these radiological studies that are able to generate really nice classifications for clinicians to work from, if you look at the data, there's still no escaping that within each of those injury classifications, there's still really large variation in prognosis. And we saw that in the AFL data with the calf injuries, central tendon or soleus injuries with central tendon disruption, well over half of the cross-sectional area of the tendon with detensioning and things. Some, as you would expect, to take longer, but then some don't.
I remember doing some lectures I did for the postgraduate program at Lateral, talking about muscle injury, and I was looking at some of the data around, the British athletics classification and the Barcelona classification. They've got some data around looking at central tendon involvement. Typically, you see that longer period, but outside of that, the actual correlation between the location or involvement of tissue to prognosis is really, really
broad.
It's really broad, and that's the clinical challenge of how we approach management and trying to ensure that we're rigorous, that we reduce any element of risk. And a challenge is that if you have an injury that does have significant pathology at baseline, but clinically they track really, really well, and there's no taps on your shoulder along the way that they mightn't be coping with the load that they're being exposed to, they're regaining their strength, everything's looking really great. And then they return, and either in their return or soon after they have a recurrence, the answer will always be that first and foremost, perhaps you didn't respect the pathology. So it's a clinical challenge.
But do you also, that can also work both ways, doesn't it? Because what if they are clinically progressing at a much more accelerated rate, and they're actually able to be involved in training and potentially playing sooner than what was initially expected? What's the approach that's typically taken then? Do you tend to be more conservative, or will that really be dependent also on
dependent on the context, the situation, the player? And that's where you're leaning on those contextual factors and team discussions. And a challenge working in the AFL is that despite some of these long-term studies classifying injuries, it is a different sport who have different training demands, who perhaps have greater flexibility with when athletes can return to competition. And even chatting with people who work in the soccer world, the ability in soccer to return an athlete and they might play 20 minutes versus if you're available, in general terms, if you're available to play AFL, you're playing at a bare minimum 80 to 85% match load.
That's an interesting discussion, because do you think that there would be benefit in that changing? And if so, does that, I guess for us as staff, that would mean potentially having bigger benches and things like that. But do you think that's inherently always going to be a challenge, that the expectation is they're going to play at least probably 80% of the game time?
It's a challenge that's unavoidable. And in certain circumstances, you could argue that if it's a problem injury that's had recurrences and things, or really severe pathology, that severe pathology has matched with a really slow clinical progression that's sort of been stop-start along the way. That's where then you need to, as a team, decide whether instead of returning to AFL, you're returning to VFL. And if you're returning to VFL, is that...
Do you have a lot more control when they return to VFL of the number of minutes they play?
Well, that's precisely the point. You can have greater scope to control minutes, control exposure, and have a graduated return to AFL level versus the boom or bust.
You're into the fire straight away.
Yeah, exactly. So, you're perhaps picking your moments there with what you do.
Yeah, I think we're doing well for time here, but I think maybe we'll end it with this: do you think that doing your PhD has made you a better clinician? Do you think it's a pathway that actually does lend itself to improving clinical practice, or do you think it ultimately is very much individualized to what you choose to do?
Yeah, I think that final point, it's perhaps individualized to what you do. And I was really fortunate in that I essentially undertook a PhD in the area that I was working clinically, and was entrenched in that area throughout.
Does that help? You think like because you and also maybe hinder because you're probably seeing things as the data's coming in and going like, oh, maybe I should try this. That would be my failing because I'm so impatient. I would just start trying to do things. And I'm like, oh, I saw this. I'm going to try that.
Yeah. I'm not sure how to answer that.
I guess it's one of those things. You do a PhD because you're interested in research, and it's still something that you continue to do now, ultimately.
Yeah, and the PhD isn't for everyone, and it was something that I was interested in and thought would improve me as a clinician. So hopefully it has.
Yeah,
I'm sure it has. I think that might be us done.
I was going to say maybe it's just removed a few years from your life, Brady. With all the
Brady, thank you so much for joining us and taking the time out of your day.
No, thanks, guys.